Hi everybody, my name's Wayne Edwards. I'm a musculoskeletal podiatrist. I've worked for 15, almost 20 years in musculoskeletal podiatry. Big thanks to Martin for inviting me today, really appreciate it. And big hugs to Andy for the slides and the help with the slides there. So, asymmetry, it's common in nature and normal and evolved in some cases. So, what is a skeletal driver? It's a hard tissue, skeletal, if you like, that influences your foot function in closed chain and kinetic gait. So, here are some examples: tibial verum, forefoot equinus, and tibial torsion. I've become slightly obsessed with tibial torsion, certainly if it's asymmetrical, so just one-sided. So using gait analysis, obviously in humans, I've come to, well, observe and say, as I say, become slightly obsessed with the fact that you get a Trendelenburg associated with an asymmetrical tibial torsion. If you see the video here, you can see the young lady, right foot, left foot, right foot, the external tibial torsion side, demonstrates with both shod and unshod gait a drop on the left side, so a positive Trendelenburg. So here it's a different patient, but in right dynamics mid-stance, you see the torsion side, there is a positive Trendelenburg. Left dynamic mid-stance non-torsional side, there is no Trendelenburg. Swing phase, this is a handy sort of snapshot when you're using the gait analysis to look at the foot position in swing to give you an indication of the torsion. Okay, so what is happening? We find that you've got an internal rotation because you're correcting, if you like, in swing phase, the external tibial torsion. What does it mean? It means that it introduces an internal rotation in the femur. If an internal rotation in the femur occurs, you potentially, and I don't know, but I suspect that you introduce a lever arm deficit. And as you can see here, this is my associate who is demonstrating very nicely a corrected version of what I've just spoken about. So if I can just take that video back again. She has an external position on the left side, and when she does her functional knee bend, you can see she internally rotates her leg and loses alignment. When she stands onto the wedge, which is about a 15 to 20 degree varus wedge, so the knee bend improves. So by changing the foot position, you've influenced, if you like, the grab on the perhaps gluteal muscle, but certainly the eccentric hip control. So from that, I can conclude that you can influence the hip via the foot, and I think that the orthotic therapy, based on, if you like, allowing an external rotation force to occur in the tibia and creating a dynamic or a mid-stance alignment, actually improves dynamic function. So the point being is that if you've got a runner or somebody with an injury that has a repeated pattern of injury on one side, if you can identify a skeletal driver, it's a really nice and quick method of teasing out what you should perhaps target as a treatment. Certainly, obviously, using muscle balance techniques and foot orthotics, you can create a situation whereby you can target or tease out quickly, as I say, the injury and help the client or the patient come away from that injury, repetitive injury pattern. I've rifled through that. Okay, so well, it's been a privilege to speak to you. I mean, I haven't done this for 10 years, so I'm slightly nervous. Some of the concepts that I've talked about in that, I think I personally would prefer to do like the breakout sessions and maybe do the one-to-one, and obviously be open to being absolutely grilled, because my forte certainly isn't presenting. But I've given it a good shot, and I hope that everybody found something useful with it.
Thank you very much.